See the question. There is no need to see, whenever you see these kind of questions, never ever try to mark the question as early as possible. Even in the exam, okay, you are not giving they will not give you any extra marks for finishing the exam 1 hour earlier or marking the question immediately. Okay, nobody will give you any extra marks. Okay, so you have your time. These days they give sufficient time, and you can read the question once, twice, thrice, if it requires 5 times, but don't be in a hurry to mark the question and just move away to the next one. 21-year-old, strong family history of breast cancer, has just learned that she is a carrier of BRCA1 mutation. Which of the following is true regarding this mutation? Breast cancers associated with BRCA1 mutation are typically hormone receptor negative. That appears to be a true statement. Usually these are ER, PR, as well as HER2 new negative. Okay, so these are known as triple negative breast cancers. Next option. BRCA1 mutation are considered gain of function mutation. Okay, what is BRCA1 or BRCA2? What are kind of genes are these? BRCA1 and 2. These are tumor suppressor gene. So tumor suppressor gene, in these genes, when there is loss of function mutation, then the cancer will occur. Loss of function. There should be suppression. Tumor suppressor genes should be less. Then cancer will occur. Loss of function mutation. Gain of function mutation is seen in proto-oncogenes. Proto-oncogenes. Okay, so this is false because BRCA1 and 2 are tumor suppressors. BRCA mutation account for nearly half of all the breast cancer. See, if we talk about this half of all the, see, all breast cancers, 90% are sporadic. Again, Rishabh will ask, do you have to remember the percent? No, don't remember the percentage, but at least if I remember, let me tell you the percentage. 90% are sporadic, 10% are hereditary. So out of all the, suppose there are 100 females, so in these 100 females, 10 will be because of hereditary, 90 will be sporadic. In this, okay, so BRCA mutation accounts for half of the breast cancer. That is not correct. That is not correct. Okay, whatever homologous and joining, that is something which you might be better in. Her lifetime risk of developing breast cancer can be reduced by half if she takes tamoxifen. Okay, so see, what we are saying, BRCA1, and we are saying that BRCA1 is ERPR negative. So if she is ERPR negative, the tamoxifen will not work on her. Okay, so that's why this is also not correct. Tamoxifen will work on the patient who are ERPR positive. Male relatives of the patient have 100-fold increased risk of developing breast cancer if they are carriers of the mutation. This statement would be true if they are talking about BRCA2. So if the patients have BRCA2 mutation, then the male relatives will have 100 times increased risk of developing cancer. But in this case, they are talking about BRCA1, and BRCA1 does not increase the risk of male breast cancer. Okay, so that's why the answer is A. A is the correct answer. A is the correct answer. No, BRCA mutation does not account for 80% of the breast cancers. Actually, I had never said this. I said that BRCA1 and 2 mutations are responsible for more than 50% of the hereditary breast cancer. In the hereditary, you can say the most common is BRCA mutation. Hereditary. Okay, not all the breast cancers are hereditary. Suppose I am sitting in the OPD, I am looking at, like suppose there are 50 patients of breast cancer. Out of these 50 patients, only 5 will be hereditary. 45 will be sporadic. They don't have anything to do with the familial or hereditary or something like that. You take the history of these, they will say that in their family nobody ever had breast cancer. Among the hereditary, BRCA1, BRCA mutation is the most common mutation. Okay, there are other mutations also. Among the hereditary, BRCA is the most common. But hereditary is just 10% of the whole breast cancer spectrum. Okay, so you need to understand this. Okay. Next question, I guess this is the last question of the breast. 65-year-old female, left MRM followed by chemo, radio for a stage 2 breast cancer. Stage 2 means either T2N0 or T1N1, that is stage 2A, and 2B is T3N0 or T2N1. When she was 40-year-old, she has had long-standing swelling of her ipsilateral arm and recently developed raised purple nodules along the anterior upper arm. Which of the following is true regarding the treatment of this lesion? Long standing swelling of ipsilateral arm means the patient had lymphedema, and I told you lymphedema occurs mostly when the patient undergoes MRM and radiation. Chemo is not important, it is the MRM and radiation will cause this problem. BRCA1, yes, most of the time it is all the three thing negatives. Okay, Nidhi, remember BRCA1 is ER, PR as well as HER2 negative. Okay, as per the you can say the new data, as per the recent data, all three are negative. All three, yes, if you have read or if suppose even if I told you as per the new data BRCA1 is ER, PR, HER2 new negative. BRCA2 is ER, PR positive. HER2 new may be negative or positive, but this is negative. This is negative. Okay, yes, you're correct, Janki Steve. This is actually Stewart Twins. Okay, so see, lymphedema may develop into angiosarcoma or lymphangiosarcoma. You can call it as angiosarcoma or lymphangiosarcoma. And I told you that usually it develops like 15-20 years later. You can see 40 years and now she is 65. So after 25 years it has developed angiosarcoma, lymphangiosarcoma, which is known as Stewart-Treves syndrome. Treatment is conservative, never conservative. Okay, this is, you don't do conservative treatment. Yes, you can change in your notes, Nidhi. If you have written HER2 positive, please change it. Okay, like breast cancer, like I said, it is a very evolving. Every day some changes are happening in the breast cancer. So maybe today what I am telling you, maybe 2 years down the line, the things might change, the percentage might change, the guidelines might change, the staging might change. Okay, so these are, surgery is a dynamic topic. It's not like anatomy that if the nerve is going from here, it will always go from here. It is like maybe once a thing which is considered as inoperable today, 5 years down the line that becomes operable. So it is a dynamic subject, so you also have to keep upgrading yourself. Stewart-Treves syndrome. Bevacizumab, angiotensin plus paclitaxel. Okay, it is not known, these things will not help. Adriamycin, chemotherapy, radiation, nothing will help. Surgical resection is the optimal primary treatment. Yes, you are right. 4-quarter amputation. 4-quarter amputation, you have to do the amputation from the shoulder joint. Laser, phaser, all these things will not help. Okay, so I guess Yes, up to 13 questions. 13 questions out of these 22 are of breast, which is one of the most important topic of the general surgery, breast cancer, breast disorders. Now we'll go to the thyroid and parathyroid part. Let's see. Following a total thyroidectomy of follicular cancer, 65-year-old female presents to the emergency 4 days later, complaining of the circumoral numbness, tingling of her fingers. Phosphate is fine. Which of the following is true about this condition? What is this? What is this condition? Circumoral numbness, tingling of finger after total thyroidectomy. It is hypocalcemia. Hypocalcemia. Yes, in females, if you want to ask female breast cancer, yes, BRCA is more common than BRCA2. Male breast cancer, it is only BRCA2. Subhashri. It is hypocalcemia. Okay, so see, hypocalcemia after thyroid surgery. After thyroid surgery can occur because of either inadvertent removal of the parathyroids, all the 4 parathyroids, or if there is ischemia. Ischemia, usually it is reversible. That is the most common cause, reversible ischemia. Maybe during surgery or something, reversible ischemia. Hypothermia can also lead to hypocalcemia, and endothelin 1 release post thyroid surgery. These are the different reasons for hypocalcemia. It likely represents hungry bone syndrome. This is not hungry bone syndrome. In hungry bone syndrome, usually the phosphate levels are not normal. Okay, phosphate levels are decreased. And hungry bone syndrome, usually you will see after parathyroid surgeries. Although thyroid may also cause the movement of the calcium, but mostly it is seen after parathyroid surgery. It may lead to shortened QT. Hypocalcemia will cause prolonged QT. Prolonged QT interval. Shortened QT is seen in hypercalcemia. Okay, although I am not a medicine expert, but at least this much I know, that it is like ulta in this QT interval, calcium. The risk can be reduced by routine post-op calcium and vitamin D supplementation. That is true. Okay, most of in our patient also, because this reversible ischemia is the most common reason, we know that patient might develop hypocalcemia, so we will give this and we'll give some time for that ischemia of that parathyroid to recover, and usually within 6 months they become absolutely okay. If you have removed it, then it is a different thing. Otherwise, this ischemia in most of the cases will come back, and the parathyroids will come back into action within 6 months. Most patients are symptomatic. Most of the patients are not symptomatic, although in this question it is symptomatic. Mostly the patients, they don't complain of anything. It is we at the time of discharge, we get a calcium, serum calcium done, and if it is low, we start the supplementation. Okay, symptoms can be this circumoral numbness, tingling sensation. Sometimes it can cause tetany, carpopedal spasm. You can check the Vostek sign, Trosev sign. All these things are there to know that whether it is hypocalcemia or not. It is more common with thyroidectomy for malignant lesion. Okay, because in benign lesions you are not much worried about leaving something behind. It is the malignancy where you are worried that you should not leave the cancer behind. So that's why you try to be more kind of radical in malignancy, and in that case the chances of ischemia and as well as removal is more common. It is mostly early post-op complication, then why it is permanent supplementation? Did I say permanent supplementation? Where is they are saying routine post-operative supplementation. Okay, routinely we give post-operative. There is nowhere it is written permanent supplementation, Rishabh. Okay, when the patient comes, when we discharge the patient, any surgical patient, we give something, some multivitamin also as routinely to these patients, because maybe after the surgery, the appetite is not good and they might not eat the things properly. So, and that is just for the like 7 days, 10 days, 15 days maximum, and then they can, when they start their own routine life, which was there before surgery, we don't have to continue them lifelong for this supplementation. Endothelin 1 release. Endothelin 1 release can also lead to this. Electrolyte changes in the hungry bone syndrome. There will be hypocalcemia, hypophosphatemia. Hypocalcemia, hypophosphatemia, and hypomagnesemia. Hypocalcemia, phosphatemia, and magnesemia. Okay, Rhythm Kumar Das. Okay, should we go to the next thing? Okay. 60-year-old female, fatigue, weakness, and confusion. History of kidney stones, pathological fractures, so stones, bones, overtones. You can say weakness, confusion, you can say like moans. So this is very typical of hyperparathyroidism. This is hyperparathyroidism. See, supplement will always help. No, see, Ullas, if there is inadvertent removal of the parathyroid, means the parathyroid is gone. So now the patient will need lifelong supplementation. But suppose there is parathyroid ischemia only, which is reversible. So after the parathyroids will start functioning again, you don't have to give the supplementation. Okay, like when you do a total thyroidectomy, you have to give thyroxine for the rest of the life, because now there is no source of thyroxine. Similarly, if there is inadvertent removal, then you have to give calcium supplementation for rest of the life. Okay, this is, I guess I'm getting another win in this case, except maybe Jasmine is correct. On physical, she has a palpable neck mass. Okay, hyperparathyroidism can be because of parathyroid adenoma. Okay, let's see, it is because of primary hyperparathyroidism. Primary means either adenoma, hyperplasia, or carcinoma. Now see, in adenoma or hyperplasia, the serum calcium value is usually, normally it is 9 to 11 milligram per deciliter. In this case, it will be like from 11 to 14 milligram per deciliter. Carcinoma, it will be more. It will be like more than 14. It can be up to 20 also. That can lead to hypercalcemic crisis. Okay, so if the calcium level is more than 14, see, parathyroid glands are very small glands. Even if there is adenoma, when the gland is enlarged, or hyperplasia, when all the 4 glands are enlarged, they usually does not become palpable. If they become palpable, if the parathyroid is palpable, okay, so in these two conditions, you should, it is suspicious of carcinoma. If the calcium value goes more than 14, if the gland becomes palpable, the first thing that should come into your mind is that maybe you are dealing with a parathyroid cancer. Parathyroid cancer. Okay, so that is the answer here. Parathyroid cancer. The treatment of this is en-bloc parathyroidectomy. En-bloc parathyroidectomy, where you'll remove the parathyroid, and the ipsilateral hemithyroidectomy, plus minus modified radical neck dissection. If lymph nodes are involved, you remove, otherwise it's not required. Okay. Next question. After a total thyroidectomy and post-op iodine ablation for a 5 centimeter follicular thyroid cancer, the best test to monitor for recurrent diseases. Okay, means you have done a surgery, everything you have done, post-operative radioiodine ablation also you have given. Now you want to see that whether recurrence is happening or not happening. So what is the best test to monitor? Serum TSH, calcitonin, thyroglobulin, or this is iodine 131 scan, or CT or MRI. Okay, so again this is the question, this is easy. E option क्यों सही नहीं है, E option क्यों सही नहीं है, E option क्यों सही नहीं है? The secondary hyperparathyroidism is because of hypocalcemia in the body. I mean, why you think that E option should be the answer? In secondary hyperparathyroidism, all the 4 glands are increased. There is parathyroid hyperplasia occurs, and in that case also the neck mass will not be palpable. Okay, so and secondary hyperparathyroidism occurs because of decreased serum calcium, and here the serum calcium is 14.8. Okay, so that is you can say rather that E could not be the answer because the calcium level is high. You need to know the normal calcium level. Okay, so that's why was saying Vishal, that's why E is not the option. It's not even close. Okay, so best test to monitor for recurrent disease is serum thyroglobulin. Yes, those who are saying serum thyroglobulin, this is the tumor marker. This is the tumor marker for differentiated thyroid cancers. Differentiated thyroid cancer, DTC, that is papillary thyroid cancer, follicular thyroid cancer, as well as Hurther cell cancer. Serum calcitonin is tumor marker for medullary thyroid cancer. Medullary thyroid cancer. Okay, so see, after the surgery, serum thyroglobulin. Thyroglobulin is nothing but is a glycoprotein which is present in the central part of that thyroid follicle. If the serum thyroglobulin after surgery, if the serum thyroglobulin is less than equal to 3 nanogram per ml, if patient on thyroxine, or less than 5 nanogram per ml, patient not on thyroxine. This is considered normal. If more than 3 or more than 5, it means there is some kind of recurrence or residual disease. So in these cases we will do radioiodine scan, and on radioiodine scan, if there is good uptake at the recurrence or the the residual disease, then we'll do RAI ablation, and if there is poor uptake, we'll do external beam radiotherapy. Now hot and cold nodules are not, they were never confirmatory for cancer. They are never confirmatory, not they are able to help to differentiate. Okay, so hot and cold nodules, see what we are talking here, Rishabh, hot and cold nodules will be seen when the thyroid is here. The thyroid has already been removed. Total thyroidectomy has been done. So where will you see that hot nodule or cold nodule? That is not even a question of nodule. In this case, if there is any uptake present, it means there is a residual disease. See, nowadays the CT and MRI is not recommended routinely. Okay, so monitor for recurrent disease, cross-sectional CT or MRI is not routinely done. Not routinely done. The main things which you should monitor is thyroglobulin, and if it is raised, then you go for radioiodine scan, and you can go for radioiodine therapy. Okay, so to monitor the disease, you have to do this. Okay, after surgery, every 6 monthly, get the serum thyroglobulin done. Okay, routine CT and MRI is not indicated. If serum thyroglobulin is raised, then there is role of radioiodine scan, then there is role of CT MRI, then there is role of ablation, then only this is there. If serum thyroglobulin is not raised, then why you want to put unnecessary radiation into the patient? Okay, so CT or MRI is not done unless you have some evidence of recurrence in this case, or so that's why serum thyroglobulin. Okay, if it is not raised, you can tell the patient to sleep in peace, you also sleep peacefully. If it is raised, then there is role of all these things, the ablation, the CT, the MRI, the surgery. They have this role when you have some, some suspicion that there might be a recurrence or a residual disease. So that's why serum thyroglobulin is the answer here. There is nothing like best test. Okay, have you ever seen a test like best test? Best test for, if you say best test for a cancer is PET CT. But where have you seen the PET CT as the investigation of choice? Nowhere. Okay, so there is nothing like best. What is best for you might be a, PET CT is like for 30,000 rupees, and you ask a poor patient to go for this PET CT, they will say that, okay, they are ready to die because they don't have 30,000 rupees for a test. Okay, so what is best for you might be a kind of test which will take everything of them what they have. So there is nothing like best or worst test. Okay, have you seen this word best or worst test? There is like most sensitive, most specific, investigation of choice, least sensitive. These terms they use. They never use best or worst type of things. The question asks first test. TSH is not the test. You have to do the thyroxine supplement. You have to do the TSH suppression. Okay, so it is a routine. It is, you have to do in all the cases. Okay, so they will not ask what is the first test after the surgery. Okay, these are questions which you are making. I don't know, maybe at the time of your classes, if you are during that foundation maths classes, this was, I used to say this, I remember multiple times, that whatever you think is not what the examiner thinks. Okay, these kind of the questions are made in a scientific manner. It's not like you ask whatever you feel like asking or whatever is going on your mind. Yes, these thyroglobulin, something you have to remember, no Vishal, is you are asking like everything percentage याद रखना है कि नहीं, याद कुछ तो याद रखना पड़ेगा ना. So at least remember this one. Okay, if because most of the time the patients are on thyroxine, so at least remember less than 3 wala value. 5 wala you forget. Next question, 46-year-old female, 3 centimeter right-sided thyroid nodule has FNAC, which is reported as non-diagnostic. What is the next best step? So this I'm sure all of you know. So all of you know this. What is the FNA, which is the investigation of choice for solitary thyroid nodule? So based on this FNAC, there are like 6 possible results. I'm not writing that. Okay, 6 possible results, which is as per the Bethesda 1, 2, 3, 4, 5, 6, where the first was non-diagnostic. So if it is non-diagnostic, what did I tell you? that repeat FNAC, and this time ultrasound guided. This time ultrasound guided. Percentage you don't have to remember. At least remember the value. No, at least remember the serum thyroglobulin value. At least remember the TSH value. Repeat FNAC. There is one more question on this. We'll discuss that. I guess the next question is also this. So let's see. Non-diagnostic. 2 is what? 2 is, I should write here. 2 is benign. So what we have to do in this case? Either follow up or do a hemithyroidectomy if it is patient's choice, or if the nodule is causing compressive symptoms. So that is Bethesda 2. Bethesda 3 is atypia of undetermined significance or follicular lesion of undetermined significance. 4 is follicular neoplasm. 5 is highly suggestive of cancer, and 6 is cancer. So in these two cases you have to go for surgery. In this case, either you repeat FNA or you go for a diagnostic hemithyroidectomy. Or these days there are molecular markers, so which is although expensive and not available at all the areas, but if it is 1C is if it is cystic. If it is cystic, okay, so that is not. If it is cystic, Rishabh, we don't have to do FNAC. Okay, so if the report comes out to be 1C, means you have done FNAC in a wrong case, because if it is cystic, you don't have to do FNAC. So forget about 1C, means you have not seen the ultrasound, and without ultrasound only you have gone for FNAC, because if it is cystic, you don't have to do FNA. Follicular neoplasm, first you will do a diagnostic hemithyroidectomy, send it for histopathological examination, and if there is capsular and vascular invasion present, you will go for completion total thyroidectomy, and if it is absent, no further treatment. No further treatment. Okay, so why did I tell you that? For the next question? Okay, next question. 51-year-old male with 2 cm palpable right thyroid nodule has an FNA performed which is reported as follicular lesion of undetermined significance, FLUS. Which of the following is true about this condition? See the options. Repeat FNA is not recommended. That is false. Repeat FNA is recommended. Molecular testing does not influence management. If the patient can afford and if the facility is available, molecular testing may be done, and that might prevent unnecessary surgery. Right thyroid lobectomy is an acceptable option. That is true. One of the option is a hemithyroidectomy or lobectomy. Total thyroidectomy is next best step. That is not the next best step. Ultrasound follow-up in 6 months is the best option. That is not best option. You can do a follow-up, but you should call the patient early. You should call the patient maybe in 3 months. Okay, so yes, option number C is correct. Option number C is the correct option. We have seen just here that in these cases, AUS, FLUS, these 3 options are there. FNA, molecular testing, and lobectomy. Follow-up can be done, but in 3 months. 3 months follow-up may be done. but it is not the best option. The best option among, if you ask me, the best option is, the best thing is repeat FNA. Repeat FNAs. In these cases, AUS, FLUS, repeat FNAs. Follicular lesion means it is a follicular pathology. Follicular cells will be seen, but it is not you can see the atypical cells. These atypical cells are not enough to say that it is cancer. At the same time, because atypical cells are present, you cannot say it as benign. So this is something which is a kind of a diagnostic dilemma for the pathologist. Neither they can say that it is cancer, nor they can say it is not a cancer. So that's why they have used the word undetermined significance. There is undetermined significance. They don't know that whether it is benign or malignant. Okay, so that is follicular lesion of undetermined significance. Follicular neoplasm can be a follicular adenoma, which is a benign tumor, or a follicular carcinoma, which is a malignant tumor. Now FNAC will not be able to differentiate. You have to see the capsular and vascular invasion, because this tumor is a encapsulated tumor. So if the tumor cells are going beyond the capsule, or if the tumor cells are infiltrating the vessels inside, then it is a malignancy or carcinoma. If it is not doing, then it is not a cancer, it is a adenoma. Next question. 65-year-old female, history of Hashimoto's, presents with fever, dysphagia and painless thyroid mass that has enlarged over a short period of time. This most likely represents. Okay, now Hashimoto thyroiditis, which is a benign condition due to autoimmune, also known as chronic lymphocytic thyroiditis. Lymphocytic we call it as because there is lymphocytic infiltration. So lymphocytic infiltration, or Hashimoto thyroiditis, although it is a benign condition and a very, very common condition, which you can see, in fact it is the most common reason for hypothyroidism. This is now I am again winning. All of you, what you are saying, it is wrong. Anaplastic thyroid cancer does not occur in Hashimoto's. Two types of cancer can occur. Increased risk of, yes, you forgot, papillary thyroid cancer and lymphoma of thyroid. Lymphoma. And in lymphoma, only 2-3 words I told you. What? It is a rapidly progressive type of cancer and lasts over a short period. Fever goes in favor of lymphoma. In lymphoma, fever occurs. Okay, which kind of lymphoma? Non-Hodgkin's lymphoma, diffuse large B-cell lymphoma. This is a lymphoma, not anaplastic thyroid cancer. This is a lymphoma. Okay, why the history of Hashimoto's are given? Anaplastic thyroid cancer usually is associated with P53 mutation. Why do you think the history of Hashimoto's and this fever is given? Okay, so this is a lymphoma. Lymphoma. Yes, the treatment for lymphoma is chemotherapy, R-CHOP, rituximab, cyclophosphamide, hydroxydonorubicin, oncovin or vincristine, and prednisolone. Okay, so this is lymphoma. Hashimoto thyroiditis, two types, papillary or lymphoma. Papillary usually seen in younger patient, and it is not associated with fever or rapid progression. So this is lymphoma. Next question. Which of the following is true regarding the tertiary hyperparathyroidism? Okay, tertiary hyperparathyroidism, see, primary, secondary, tertiary. Primary because of some parathyroid problem itself, parathyroid adenoma or hyperplasia, or carcinoma. Secondary is because of hypocalcemia like chronic renal failure, vitamin D deficiency, malabsorption. Medullary thyroid cancer can also cause. And if there is prolonged secondary like chronic renal failure, and after the renal transplant, now because of prolonged secondary, the gland becomes autonomous, and now it will keep on producing increased PTH irrespective of the calcium is normal or high or whatever, it will keep on producing. Okay, so that is tertiary. Now we'll see. It is usually due to underlying parathyroid carcinoma. That is wrong. It is most commonly seen after successful kidney transplant. That is true. Serum calcium level is usually normal or low. Serum calcium level is normal or low in secondary. Usually in these cases, serum calcium level will be high. Distinguish between secondary and tertiary is essential because the management differs. That is also wrong, because initially when there is secondary or tertiary, you start with the medical management. Okay, so people generally they don't try to differentiate, but in tertiary the medical management will not work. Medical management will not work, and you have to go for surgery in this case. In this case, if medical management works, then no surgery. If doesn't work, then surgery. So that's why initially you will give this only. Later on, when you know that the medical management is not working, then you plan for surgery in these cases. It only occurs in patient with chronic renal insufficiency. It's not correct. It occurs in any case in which there is prolonged secondary hyperparathyroidism. It can occur in any case where there is prolonged secondary. So option number B is the correct answer. So this was a difficult, I feel that all these questions which you have done till now are not easy questions. You are marking it nicely, but yes, few questions so you will not be able to do. So this was one of that question. This is very easy, straightforward question. I am sure all of you will be able to answer this. Very easy. During thyroidectomy, the superior thyroid arteries were ligated a centimeter away from the thyroid calf. I told you these days the vessel should be ligated. The main trunk in fact should not be ligated. Suppose this is superior thyroid artery and these are giving branches. Only the branches of these vessels should be ligated. Okay, suppose it is superior thyroid artery or for that matter inferior thyroid artery. Just ligate the branches which are entering directly. Now, this technical error would most likely result which of the following complication? Please explain option B again. Option B is, see, I told you that suppose patient is having chronic renal failure, patient is having secondary hyperparathyroidism, and now because of chronic renal failure, even after you do the renal transplant, now renal transplant has been done, up to any hyperparathyroidism here, before renal transplant, that will be known as secondary. Now after renal transplant, whatever the reason for hypocalcemia, that is corrected. So now the calcium level will be normal or will be high because you have done the transplant, but still the patient is having hyperparathyroidism because the gland has become autonomous. So now it is not looking at this calcium level, it is just producing, it is keep on producing excessive PTH. So that is the meaning of this, most commonly seen after successful renal transplant. This technical error would most likely result in which of the following complication? Okay, so just here goes the external laryngeal nerve. Here goes the recurrent laryngeal nerve. Okay, so in this case, if you are ligating the artery away, you are injuring external laryngeal nerve. That will cause loss of pitch or tone to the voice because it is the tensor of vocal cord. It supplies the cricothyroid, which is the tensor of vocal cord. So that will result in loss of voice projection. I don't know why you are saying C or D or whatever. This was easiest. This was something which I thought while putting the question that okay, this question to everybody will tell. Okay, so those questions which were difficult, in those you are doing well, but in the easy questions you are doing bad. And this is a easy question. Hoarseness occurs if there is unilateral recurrent laryngeal nerve injury. Loss of airway will occur if there is bilateral recurrent laryngeal nerve injury. Aspiration and ineffective cough, although it is not seen in thyroid surgery, it is because of internal laryngeal nerve. Okay, internal laryngeal nerve injury can lead to loss of sensation in the larynx or pharynx. In the larynx you can say loss of sensation, and now because of that when something is going, the patient will not be able to cough, and that can lead to aspiration. Okay, so this is loss of voice projection or loss of pitch or loss of tone. Anything related to the voice is external laryngeal nerve. Okay, so this was a easy question. This was an easy question. Hoarseness, aspiration, that is, I thought it is superior thyroid artery hematoma complication which may cause respiratory. No, they are not saying that there is anywhere in the question. See, that is the problem. Don't think extra thing. Whatever is given in the question, that is the information they are given. Don't assume anything that there must be a hematoma that is causing respiratory depression. No, not that. Okay. Last question, and we are done for the day. 45-year-old man, history of primary hyperparathyroidism, presents for an enlarged thyroid nodule. Present with an enlarged thyroid nodule. Further workup reveals elevated calcitonin level. Which of the following is true regarding the most likely condition? Yes, internal laryngeal nerve in the laryngeal surgeries, that can lead to all those things. So now you need know there is hyperparathyroidism. There is solitary, okay, you can say thyroid nodule. There is increase in the calcitonin. So what do you think is this problem? What do you think is the problem? Hyperparathyroidism, thyroid nodule, calcitonin. Thyroid nodule with calcitonin means it is medullary thyroid cancer. Medullary thyroid with hyperparathyroidism means there is some syndrome, which syndrome? MEN2A syndrome, which is also known as Sippel syndrome. Yes. So which of the following is true regarding this medullary thyroid cancer? Bilateral prophylactic central node dissection is indicated in addition to total thyroidectomy. That is very true statement. Radiotherapy is effective treatment. Radiotherapy has no as such role in medullary thyroid. Plasma or urine metanephrine do not need to be checked. It is must to be checked. Okay, you have to check this because in MEN2A, if there is FEO, then FEO needs to be treated first. Okay, otherwise, suppose there is pheochromocytoma, you have not ruled out pheochromocytoma, and you are taking the patient for medullary thyroid or for hyperparathyroidism, then during surgery, because of this pheo, hypertensive crisis may occur, and that can be life-threatening. The likelihood of nodal metastasis is low. It is very high in medullary thyroid cancer. When the cancer present as a nodule, the risk of nodal metastasis is more than 50%. Chemotherapy is effective for residual disease. Chemotherapy is not effective. In fact, in any case of the thyroid malignancy, chemotherapy is not the preferred treatment option in any case. Okay, so the best answer and the only true answer is A. Bilateral prophylactic central node dissection is done when we are doing surgery for a medullary thyroid cancer. Okay, this is very much clear. In medullary thyroid cancer, even if the lymph nodes are not involved, you have to remove at least level 6 in all the cases. At least level 6 you have to remove in all the cases, no matter if it is involved or not involved. Okay, so with this we finish our session. I hope it was a kind of a quick revision, and to approach the question, how you should patiently read the question, think about it, don't think too much also. That is also a problem with you guys. Okay, so don't think too much, and all these questions are the like standard questions, a bit difficult questions, and if you're doing well in these questions, I can imagine that your preparation is good. And I wish you all the very best for your exams, whatever exam is upcoming for you, and we'll see again, we'll meet again, we'll talk again in some other form. Okay, so thank you very much, and it was a lovely discussion and a fruitful discussion with you people. So thank you very much, and God bless you all. Good night.